So before I get on to the deep part of the topic, I will give a background as to how this evolution happened from being a hardcore surgeon, really spending 4 days a week in an operating room, to thinking beyond what happens in the home. These are my disclosures, which have been reviewed, nothing pertinent to this law. I am one of the research scientists for trials which are happening. But yesterday, the guy said Tim arranged for me to be shepherded by a couple of residents, different parts of the journey. And me going to one of the events was with Icahn. And Icahn started talking to me that I must have been coached by someone. That why you chose prostate cancer. And it was a really profound topic for me to answer just within seconds of that 10-minute ride, and which he's trying to find his way into the garage. So I really, but that was really relevant for me because it had an old story, and you can sum it up by one word, that I wanted to be a gentleman hunter. And I will explain what that means. And I wanted to choose a disease, a cancer which was common, which was potentially curable. And I am a people person. I didn't want to just deal with the patient for a short while. I wanted to have a relationship for a long term, possibly decades. And prostate happened to be one of them. And it was not just removal, it was a lot more than removal in prostate cancer. So that's the way I got interested in prostate cancer. And at that time, when I had come to the United States in 1993, it was Dr. Walsh who was the CEO. So, and what he did, prostate. So that's how I got interested in it. But this gentleman hunter has a background. Early 1900 in India, where I grew up, this was not too far from my place where I grew up. It was not in the hills, it was in the plains, but within a 6 to 8 hour train ride, which the only thing we used to do, we can go to foothills of Himalayas. And we used to collect stamps, and these were the stamps we were collecting at that time. And I used to spend some time with my grandfather, who just, I asked him, what is this stamp about? Why are they showing tigers and all those things? Then he told me about a story that in India, there are about 3,000 plus tigers. The highest number of tigers in the world are in India. And they are common partners, like you see bears here, you don't mess with them. Tigers used to be that kind of animal. But suddenly something happened when tigers started getting crazy and they started killing humans. And it became a major issue at that time. And they were, Reader's Digest covered will write up, the books were written, and they were called as man-eaters of the mind, or man-eaters in India. And something happened. And that led to people getting really crazy on the other side, and they started killing every tiger they could. I'm deliberately not showing that picture because I thought this morning now, dead animal is not a good picture for me to show. But bottom line is that a lot of people started killing tigers who had guns. But they killed tigers, but they didn't kill the man-eaters. Because man-eaters were hiding, they were much more smarter than those other guys, and then they were just hiding out, and the innocent tigers were getting killed. Then came a special hunter, his name was Jim Carroll, who was smart enough to differentiate, who was accurate enough to kill, and who was caring enough to really worry about this thing. He got to the tiger, he took care of it, but protected the rest of the tigers, and there is a bird sanctuary or a tiger sanctuary in India known as Jim Carroll Park. If you ever go to India, you should go there. So that clicked on me because there are similarities between what we were doing in prostate cancer and what Jim Carroll had to face 50, 60 years ago. So in my mind, there are three different kinds of prostate cancers. One are stuff like this. I mean, recently we were talking about guidelines. The others may have a fang, and this one doesn't even have a fang. Reason 7 3 plus 4 may be like this, or reason 7 3 plus 4 maybe 4 plus 3. So we don't know. And then there are reason 8, 9, and 10. They are legal. But we don't know how to differentiate them. And at least 10 years ago, when I got really interested in this field, 10, 15 years ago, there was a lot of reason 6s being operated in at that time. And there were concerns. That's where the US Preventive Task Force was thinking about different discussions. And this is a picture of one of the legal reason 10 which finally got to my patient. I lost it. This is a reminder for me that as a surgeon, I thought I was very good, but this happens. This happens. Every one of us had lost the battle with cancer journey. And while yesterday was the day in which I was refining my skills as to save and take care of the surgical crowd, my other part was being bothered that not everything can be treated by a knife, and in my case, with a robot. So what else can we do? I started reflecting upon that. And I realized that the prostate cancer problem is in cancer designation problem. This guy is wolf, everything else is sheep. But there are so many of them that we kind of forget about it. We go, the pendulum swings from one side to the other. Prostate cancer is a cancer people will die with, not die because of. And still we manage to have issues with the mortality, which is increasing in the last few years, and I'll show that. So I started investing my time in the molecular biology disparity. Certain groups had cancer which were more aggressive. First time I'll see it and it will be more aggressive. Imaging was a major investment in my mind. I have got really a large pool of patients who are on an active surveillance, about a couple of thousand. I was working on the nerve sparing precision medicine, but then suddenly it started steering towards the immunotherapy discussion, and I'll come and talk about it. And most of these journeys in my mind happens through interactions. I will go back to my program, learning a lot what I learned from Isaac. I mean, I think what I learned from all of you, and something will be incorporated, something will change. Same way in my journey, I have interacted with many people, and every interaction led me to kind of become a little different. Dr. Menon's interaction got me into the robotics. There were other people in Innsbruck and other places who forced me to not to use cautery. Some people were anatomy people, from Takinaka to other people that I got into the anatomical dissection. I interacted with a basic scientist, Mark Rubin, in early 2010, and I got interested in genomics. I moved here, and I got two gifts. One is Dr. Sujit, who is sitting with me, he's a PhD, he's an assistant professor in the department. Another, recently, Dr. Nina Bharadwaj had joined my program as a cancer immunotherapy program. And she's very close to Jill Allison, she's in that league. She was sitting with Jill Allison when she was getting the Nobel Prize in that room. So she is of that caliber, but she's kind enough to talk to herself. Meaning she is patient enough to tolerate our ignorance. So over time, we started having meetings, and as I was saying that every Saturday I spent 2-3 hours with the team, even on Wednesday, Friday, and in the afternoon. So I evolved in that journey with the immunotherapy discussion. It was pretty exciting to me that the immunotherapy can cure, and at that time, melanoma was being cured, certain kidney cancers, and there was data coming out that immunotherapy may be one of the cancers. Immunotherapy, one of the strategies that can help cancer patients. I'll come to that later, that prostate was not the most friendly one, but I got excited about immunotherapy. And as you can see, there are many people here, from a medical oncologist to high definition genome sequencing to Dr. Menon and a pathologist, and a lot of the people who actually contributed to my evolution, and they are part of the program right now. And I'm sure I missed a couple of them in this picture, which I will update later. So I want to bring you to the prostate cancer journey, and let's start reflecting upon prostate cancer. That about 2,700 years ago, this is the first ever documented and DNA verified prostate cancer case. That was known as the King of Icahn. He was in Siberia. He was pretty strong. He got prostate cancer, killed prostate cancer, defeated him through doing what it did, what you are seeing in the books. So, even its strongest can have prostate cancer, and it has been with us at least for 2,700 years. With that background, I want you to see what is happening inside the prostate. And in this room, everyone knows the prostate, that you go inside each Sinai and one cell becomes abnormal, it becomes Icahn 6, then it breaks through into the stroma, and then we call it a 4, and it becomes 7, till it evolves closer to the nerves, it is okay, then it comes close to the capsule, close to the nerve, close to the blood vessels and lymphatics, and then it becomes what we call a problematic cancer, a legal cancer, or extracapsular cancer. And this is the journey of prostate cancer. Early on, it is curable, then it becomes a little bit problematic. And I really studied what was happening at the gene level, at the molecular biology level, and I will not go into the details of it, but the prostate cancer is a pre-clinical cancer, becomes a localized cancer, many of them get cured, small proportion comes back. That comes back initially is insensitive to the hormones, later on becomes insensitive to the hormone. There is a phenomenon which is happening in which epithelial to mesenchymal transformation, lot more aggressive clones which are evolving. All that said and done, bottom line is at the end of it, sometimes cancer wins. And that sometimes, I will come to it, still is the good part. So from an immune standpoint, I was thinking about, if I look at myself starting in front of you, I'm about 37 plus trillion cells. Skin, gut, kidney, prostate, bladder, blood, all those things is about 37 trillion cells I have. Out of that 37 trillion cells, about 1 million die every minute. I lost a couple of million cells in last 5-10 minutes, what I was talking about it. 1 billion cells are replaced by the end of the day, and literally 1 trillion mutations happen in my own body every day. That trillion mutation, every mutation has a chance that the cell can become cancerous. But that's not the incidence of cancer which we have. So there must be something right which is happening in our body, that we don't get trillion cancers in our lifetime. When we get unlucky, we get it. So that happens because of two different mechanisms which are built in. One is that there are
environment was like very heteronormative, straight.
Is there a question?
No, no.
So there could be that the fail-safe mechanisms are there, that the proofreading mechanism in our body, that every time there is a cell division which is happening, is taken care of. And then the second part is tied to another 3 to 4 times trillion cells, which are part of me. You are not seeing them, but they are the microbiome. What I mean is that 3 times of my 37 trillion cells are the microbiome which I'm carrying, I'm breathing, are in my gut, my skin. And they have been with me whole life. They have been changed sometimes because of antibiotics, they have changed because of certain changes, but they have been with me. And over millions of years, humans, or for that matter, any living being, has dealt with this coexistence of a microbiome. So, body has developed what we call immune mechanism to deal with that. Usually, it used to be dealing with as an infection, pathogen. But the same mechanism which protects us from that most of the time can actually protect us from developing that cancer. So, proofreading mechanism and also an immune mechanism built in our body isn't contributing to why we don't get that many of cancer. If you look at it, what happened to that king of Ezra 2,700 years ago? We made a lot of progress. But in the last few years, because of some changes in our PSA understanding of PSA uses, the mortality is going up. And I'm just undoing what is being talked about a lot in the media, that the prostate cancer with the Protect trial comes and all those things stuff. We kind of minimize prostate cancer sometimes. And I don't like using this, but I have to show you this. Who can identify what is this? It's a Boeing. Can someone tell how many people vote in Boeing? 700 to 800. And what is the number of people dying due to prostate cancer in the world every day? In spite of it being insignificant cancer, in spite of we being very good in treating, all that said and done, today's day and age, in the world, one plane, at least one plane, sometimes 1.5 plane, crashes with all the passengers dying the moment they take off. And that's the mortality of prostate cancer right now. Our problem is that thousands of planes take off, which are confusing because they are the active surveillance candidate, but all said and done, still these people are dying. Their solution cannot come 10 years later. Their solution has to come at the check-in when the TSA is checking them that, hey, you are on the wrong flight. That will establish the fact that why I'm interested in it as a surgeon to find other means of finding a solution. So that sets up the background. Then I started studying a little bit more about the genomics and understanding the DNA. I will not dwell too much upon it, but bottom line is that's a field which is evolving, and a lot you will see. Just like we are talking about AI now, 10, 12 years ago, we were talking about genomics, and we were on the right trajectory. It has given us a lot of tools. And this genomic information helped us in differentiating cancer above and beyond basal. And we started talking about that cancer can have a different molecular subtype. One may be related to sugar, other may be to the testosterone, and third may have nothing to do with androgen, but it's the DNA pathway, will pathway. So you need to know what you're dealing with before you can choose a poison for that particular individual. And at the molecular level, cancers are different, and that was an important information for me. And then the DNA repair pathway may have something to do to make the cancer more visible to the immune mechanism. That is in secondary discussion. So now I'm going to zoom into a little bit understanding of what happens in cancer journey. Basically, in the prostate, certain cells, they go through the same mechanism, but still find some mutations. And mutations happen because of chemicals, because of overstimulation, because of lack of certain immunosuppressants, may happen because of some chemical exposure. We have patients who are exposed to the ground zero exposure first time during 9/11. They have more prostate cancer. Patients who are exposed to Agent Orange, they have more prostate cancer. There are certain genomic groups, like Dr. Carroll was talking yesterday, that certain germline mutations can also predispose for the cancer. But bottom line is, some cancers happen. There is an elimination by the T cells and the NK cells and the dendritic cells within the organ, and they are over the field. But if the T cells are a little distracted, they are dealing with the COVID on the same time, and the prostate is having some abnormal cells, they deal with COVID, but by that time, those cells escape. And these cells now from in 5 to 10 became a couple of thousand. And not only they escape, they change their texture. So there is a clonality, there is a clonal evolution of the cancer cell which is happening, and that clonal evolution, so by the time the T cells figured out the first clone, the second clone is a little different, they are still not differentiating who's good and who's bad. So then there comes an equilibrium that neither they are increasing nor decreasing, and there is a balance. And ultimately, cancer cells figure it out to become totally resistant to the immune mechanism, and then they become invasive cancer, the lethal cancer, the metastatic cancer. So the escape part happens. So we call it three E's of immunoediting, and you all have read this in the basic medical books for basic immunology. But that is what is happening at the cancer site. And a couple of my favorite cells are the NK cells, the dendritic cells, and a couple of T lymphocytes which actually execute this process. It's not through the antibodies as much as it's happening to the cells. And I give an example living in New York City that in New York City, every time you park a car in the wrong place, there is an NYPD person who is scanning your car and checking out if you're overdue or not, and then you get a ticket. Sometimes we call the other NYPD guys to come and take care of it. And you will realize that this person doesn't have the gun. He's just had a scanner to check it out. So these are our what we call the ABC cells or the dendritic cells sitting in the tissue in the neighborhood, scanning for everything, but cannot leave. But they can create trouble for you by getting the right people called. There are certain NK cells which are there which can be stimulated by these dendritic cells, but they stay calm most of the time. What happens then? There is a recent in different parts of the city, different parts of Connecticut, that they make a call. There are a couple of real cops sitting with guns and every other ammunition, and they're okay, come and I'll come and check it out. But are you sure they are bad? And that are you sure you are bad is in what we call the checkpoint inhibitors. Because these cops can kill, they are very well trained on not to kill. So there are 1, 2, 3, and at least I know of there are many more checkpoints which are there. At least the checkpoints CTLA4 got Janarison and Overtime. But there are many more which are growing. But bottom line is these NK cells are very lethal, but there are fail-safe mechanisms. You have a gun, but it only works with the fingerprinting. And unless and until the fingerprinting is done, then you have to have a Google's two-way authentication. Someone has to confirm that, yeah, it is strong thing, let's do it. And this process can be sometimes hijacked because these cancer cells are not the cells which have come from outside, they are our own. So they have our wisdom plus a little bit problem. So they sometimes figure out a way how to send a wrong message to these lymphocytes to tell them that, you know what, I'm not bad, I'm just different, don't bother me, I will not bother you. So there are mechanisms which they use to send the wrong messages to the T lymphocytes, and that all is a combination of things why cancer will grow, but cancer will get controlled. So there is a lot of millions of years of wisdom is in this process, and I must say that these are my favorite cells that once the T lymphocyte is really taught that it is a bad cell, it can take care of it. But I want to take you through a journey, and that will tie into a discussion that we were having yesterday. I'm not talking about MSc class 1 molecules and class 2 molecules and HLA and HLA-T's discussion to this audience. But basically, there is a passport of research carries, and that passport needs to be picked up by the antigen processing cells, like dendritic cells, which are the tissue-resident cells which identify something abnormal in the cell. Then they go to where? They go to the lymph nodes. And in the lymph nodes, these T cells are sitting there, and then they go and talk to them. They give the fragment of that molecule which was picked up on the abnormal cells and tell them that, you know what, I found this. And there are millions of T lymphocytes sitting there. 1 or 2 of them say, yeah, I have been able to identify this one. First thing they will do, that T lymphocyte will get up and multiply. So, okay, before I go and check it out, let me make sure that I have that number plus. And then they come back to the organ. While they are coming to the organ, there are problems sometimes which can happen that they will not have an access because tumor cells have created fibroblasts in their favor. And I'll come on to that. That they cannot reach it. But if they manage to reach there, they can identify the abnormal cell and they have the fail-safe mechanism overridden, they can kill the cells. So this is known as a cancer immunity cycle, and that's the reason I have a problem with removing normal lymph node in them. That was the theoretical discussion, but I must say, please don't take it as a fact. This is a hypothesis at this point. So I'm challenging your mind in that process. If you are doing a surgery or if you are taking a board exam, you have to follow what NCCN guidelines and what AUA guidelines are. And that's the reason I said I will take the lymph nodes out, but I have to concern that 6,000 or how many normal lymph nodes I took it out because it's supposed to be. And I have a theoretical problem that if the lymph nodes are the place where they are getting reactivated, and I just dismantle the entire system. Focusing on this, now I want to take you to the prostate area itself. This is the image I showed you yesterday also. I will stop somewhere here. Basically, what you're seeing that the prostate has a capsule, prostate has an abnormal cell, but while our eyes are looking at an abnormal cell, we are looking at the lesion. What are we looking in the lesion gradient? We are looking at abnormal acidular structure. What we are not looking at it, and I give an example sometimes. If you go to a garden, you're looking at the rosebuds, you're looking at the chrysanthemum, you're looking at the tulip. Eyes don't look at the large green which exists in any garden. That large green is the stroma. And the stroma in cancer is very active. It has an impact physically, chemically, in what it allows to travel through and the signaling. It can change what you call the tumor microenvironment into a friendly one or an unfriendly one. That all happens, and there are cells which come from different, what we call the myelin. That cells can come, stem cells can come, regs can come. They all have a different messaging code that whole process to orchestrate. But whether the cancer will be identified and killed or not killed is a fine balance between the cells, genomics, mutations, tumor microenvironment, physical barriers, and all that is orchestrated between the cancer and the body's defense mechanism. So I want you to know there's something known as a reactive stroma, there is something known as an immune suppression, and there is something known as chronic inflammation. I have talked a little bit about the reactive stroma, I have talked about the immunosuppression, but chronic inflammation can be a good thing, but if it has been there for lingering time, body gets exhausted, they figure out a mechanism in which they confuse between inflammatory process and remolding and tissue regeneration process. And they got cross-connected, and that is where the cancers can become a little bit more aggressive. There is a pathway known as an abnormality, which if it gets activated, it can make the cancer a little bit worse cancer than what it is. So all combined, all three things are happening, and it's a fine balance between these three that the cancer will be going to the next step, or will just stay like it is in sick prostate cancer. So, looking at the prostate cancer, prostate was not a good tumor for me to embark on immunotherapy. That's a fact. Very many people have tried, and bladder is a good one. Kidney is a good one, but prostate is not. So we start talking about a term that is the cold tumor part. It's a very simplistic surgical level simplification that there are the tumors which are very much populated by these good cells and less by the bad cells, and they are likely to respond to the immunotherapies because they already have the resources available locally at the site. They are known as hot tumors. But I have a picture, I think Sujit is our picture. Yeah. So Dr. Nair is the one who is leading this initiative from a PhD standpoint, and he is an amazingly hardworking and smart person who really works more than surgeons. That's all I can say. And he has put together all of the data which we are talking about, and that's the reason I wanted to respect him to be in the room so that he can correct me when I'm not doing the right things. So you can see this histopathology slide, and we are supposed to see some T lymphocytes, and this very bizarre. There are no cells, much more immune cells in the prostate, and that is the problem because I want tumor to look like this, not like this. And that simplistic approach I took, can I make the prostate tumor hard? Then I have a hypothesis, and the next one is an absolutely not a fact. It's a hypothesis. So I want you to, and I will hopefully get some feedback, not just now maybe, but later on, why is prostate so cold? And I have a hypothesis that there is one of the most immune privileged sites in the body is testis. It is because the testis is trying to preserve the sperms from getting killed from the immune mechanism. And there is the same mechanism goes on to the birth canal when the sperm reaches the other person, and it also doesn't get killed, it gets somehow managed. In the journey of the sperm from the testicles to the birth canal, there are few stations, and prostate happens to be those stations. I don't think body is that naive that it will protect the sperm at the testicles so well and let it get killed at the prostate because that's where it stayed. So we started looking at that. There are things which are being produced in the testicle. They are finding its way into the prostate. We have some preliminary data to talk about it. And one of them, TGF-beta, is one of the chemicals which is a dual-edged sword, which can be an immunomodulator. And again, I started with a statement and I'm ending with a statement. That is our hypothesis. Not been tested. We are looking into it. But that, my mind is that that's the reason prostate is not a very hot zone, because body doesn't want it to be a hot zone. You don't want to send your sperms through that journey where the moment they go to the prostate, they are all eliminated. It doesn't make sense to me. So with that background, I started thinking about how to make it hot. And this brings me to the journey of Dr. Cooley, the William Cooley, who was at Memorial Sloan Kettering a long time ago. And he had a couple of tumors in which started with the tumor getting infected. And that infection led to him just kind of abandoning the case that it's not going to help now. I mean, we cannot do much. And few years later, finding that tumor actually disappeared. And the most notable case is Mr. Zola. And he was an Italian immigrant who had this tumor in his neck. And he started injecting some special kind of bacterial toxins, basically making the tumor inflame. Not a very scientific way of going about it. A lot of controversies happening in that. But that started a field of tumor immunotherapy at that time. And that led me to start thinking, I don't have to put in an infection in there, but can I use tumor itself as a vaccination source? Because when we vaccinate, everyone knows about the vaccine, at least in 2023. So those vaccines are attenuated certain molecules, certain parts of the living thing which we use it. But tumor is not coming from outside, it's within. If I can somehow disrupt the process in which they are protecting those antigens and unmask them, can I use them as a vaccination tool without making them aggressive? That was the theme. And we launched this trial. This is known as In-Situ auto-vaccination in prostate cancer in a Neo-Adjuvant setting. The theme was very simple. I'm going to do the surgery in these patients. Only thing is I'm delayed by 4 weeks. 6 weeks it normally takes for me. I was going to wait for 4 to 6 weeks more before I do the surgery. They will get the same treatment. They will get everything out. And let's see what happens. That was the mindset. And what my mind was thinking that immune system, we are testing it when the battle is really big. It's not really big. You really need real chemicals, real hormones, real other treatments. But early on, if we get this system activated to identify the bad guys, then those bad guys will try to stay the primary organ and circulating around. These T cells are circulating everywhere. Later on, they can help us in that process. That was the theme. I didn't give the real battle to the immune cells. I just wanted to become my spy for the future. So with that mindset, we started using something known as a poly-ICLC, and I'm coming back to that. What is that? It's basically something which immune cell thinks is bacteria. Thinks is bacteria. It's an chemical which has been double-stranded RNA, and it activates the response, what we call pathogen-associated molecular patterns, and the sensors, they get really crazy. There are TLRs, and there are TLR3 which gets active, and there are pathways which are normally used by the suppressor cells, like RIG1 can also be used by this, and it basically creates an inflammation or a havoc in the local system that something bad has happened. We are being hit. Let's bring in every resource we can. So poly-ICLC is a double-stranded RNA which can be used to evoke an immune response within the region. So that's what we started. We started with taking the tissue before surgery, the biopsy tissue before injecting something, then injecting something, giving a booster, and then a few weeks later going and doing a radical prostatectomy. That was the theme. These are the examples of, they had MRI pictures before. Using MRI picture, I did the targeted biopsy. And this is what happens when I inject something. It's very easy. It takes literally 2 minutes to do it. If you know the lesion, you can inject something. If you're not injecting the local outside, you're just basically injecting same needle. Nothing else is different. And patient doesn't get any pain, no other problems in this process. So we started that protocol. Only change which I will suggest that when I was doing this, I was using transrectal approach. Of late, I've been using transperineal, but in this cohort, there is no one transperineal. But I'm thinking about transperineal also, both as a positive and both as a negative. I will intellectually talk about it. So, but this is what I did. The whole prostate was taken out. There was an injected area, there was a near normal, there was a contralateral normal, there was contralateral cancer. So all that area was defined. We looked at that this was a safety study. This is a phase 1 study, so it had to be a safety study. We wanted to make sure nothing bad is happening. Other than one having fever, one patient 6 weeks later having DVT, and some pain issues in the local site, there was no side effect. And I do get DVT in my normal patients after radical prostatectomy, and I will show you what kind of patients were these. So this is the biopsy Gleason of these patients. There were 12 patients who are recruited. Everyone read as 8, 9, or 10. There were 10s, there were more 9s, there was 1 8. And there were 2 patients who were 7, 1, 3 plus 4, 1, 4 plus 3. The other red is what actually happened to these patients when I did the radical prostatectomy a few weeks later. The red is essentially saying that they were still Gleason 8, 9, 10, and everything else was 7. Then there was a feature about whether they had a persistent PSA or not. So 2 patients, one with a lymph node positive and one with a T3A, T3B cancer, they had a persistent PSA, meaning their PSA never went down. Rest of the group is here. 2 patients got a PSA a little high and have not needed any kind of salvage therapy in last 4 or 5 years. And bottom line is here. In my poly-ICLC cohort, red became white in 66% of the times, meaning there was a downgrading. Then I looked at my own cohort, what is my average downgrading in that kind of a patient? That is about 27%. Then the next thing, I think I'll use this, 27%. I have Dr. Menon with me. He has a large cohort of patients with Akshay and everyone. It was 20% in his cohort. Then I went and looked back at 2006 paper, Dr. Easton, who had an MSKCC cohort, and he had about 45% downgrading when he started with the Gleason 8 in the biopsy. Even if we look at this, 66% of the patients got downgraded in my cohort. 5-year PSA recurrence was 25% in my cohort versus 62% in that cohort. 5-year PSA recurrence in patients who were Gleason, whole cohort had 2 Gleason 7s. If I look at only those who had Gleason 8, 9, and 10 in the biopsy, that is about 30% versus 49%. Those who had an organ confined cancer, ultimately in my thing, 60% versus 30%. And those who had T3 in my cohort versus MSKCC cohort, 20% versus 64%. So I didn't get any side effect. And then something happened just in 6 weeks. How many weeks was that? 6 weeks. Yeah, 6 to 8 weeks. And they all got the same surgery. When I look at the PSA recurrence data, my standard versus poly-ICLC patients, the PSA recurrence data is like this. When I look at from a pathological standpoint, when I look at the aggressive cancer and the decipher and everything connected, it seems like they are having a lesser PSA recurrence. So that was a very true clinical outcome. That was not supposed to be an outcome. Safety was the outcome, but this is a fringe benefit. And how long has been the follow-up so far? Over 40 months. Over 40 months. So we are in process of, so don't post it. Paper is supposed to go out and go to July weekend. So. Then we started looking at, we did in multiplex immunohistochemistry in pre-treatment and the post-treatment. And this is how the cold tumor looks. And these are each one of those patients, cohort 1. And this colored structures are what you are seeing, the T lymphocyte infiltration. We started with the same patient before radical, before injecting anything, and after injection, this is what is happening. It continues in the higher doses, it continues more. So classically, from a pathological standpoint, if I have to say, we did make the tumor up. That was my goal. And there is a pathological term which my pathologist, Dr. Ken Haynes and Swati are coming out, that they are calling it tumor acinitis. Something has happened that the tumor is inflamed now. And when you look at the tumor, this is the perineural invasion, and that seems to have gone down on this cohort after the radical prostatectomy. And there is a new discussion coming out that are there secondary lymphoid follicles being produced in an organ? And these are classically known as secondary lymphoid follicles. Just by injecting something into the prostate, we have been able to make the tumor a little bit more inflamed, and the secondary lymphoid follicles, maybe not secondary, I think they're tertiary. Sorry. Tertiary lymphoid follicles, they call it. And then I started looking at Sujit level of discussion, in which he has 20 different markers, which include the mitotic spindle, T cell responses. Bottom line is the good things are happening. The T cells are getting accumulated. Mitotic spindle is going down. Metastatic signature is going down. This is the same patient before, and this is the same patient afterwards. You look at the PD-1 expression changing, CDLA4 expression changing, KERS expression changing. He did different kind of 300 gene expression in a special kind of plot. And basically it says that DNA replication goes down. Genes that are supposed to be good for cancer are going down. Genes which are being killed by the cancer are going up. This is looking at the NK cells and the B cells before treatment and after treatment. You can see that more B cells are there, but NK cells are really high. Pre-treatment, the number was this. Post-treatment, the number is this. And not only that, they are high in number, the NK cell. NK cell can be a sleepy NK cell, it can be an activated NK cell. And these are predominantly what you call an activated NK cell, and they also have the CD8 positive NK cells in the tumor microenvironment they are looking at. And when you look at the poly-ICLC and put it into an explant model, there is a more interferon response in the explant model. They have a Gleason, and especially there is a new marker which is coming out known as an IDO1, which if it is active, it's saying that there is a good immune response going on, and that is also there. Then we started looking at what's happening in the blood, not only in the tissue, because this was in the tissue. And basically, it looks like the body is inflamed. Body has some markers which are anti-cancer and pro-body's control mechanisms. And this goes on for 6 weeks. And when you look at the special kind of cells, these cells are circulating in the body. So they can be going and checking out the lymph nodes, they can be checking the bones. And we wanted to change a blue cold tumor into a bright red hot tumor. And it looks like we did achieve it. One more thing happened. That the same tumor, which didn't show many mutations and antigens, there is a special kind of an antigen which is being talked about. It's known as the Neo-Adjuvants. If they are present in a tumor, they get picked up by the cancer cells, by the immune cells very easily. So something happened that the poly-ICLC induced the new antigens, and we looked at the biopsy and looked at the main specimen. And bottom line is we have a protocol going on that if there are new antigens in a patient, we can make a specific vaccine for those new antigens for that particular patient. So we have a second clinical trial going on in which we are finding if there are new antigens. Not everyone has, but if it is there, we could develop a vaccine and bring that vaccine back into the patient that is specific for that individual. And basically we found that there are multiple mutations which are present now after post poly-ICLC injection. And we now have a personalized vaccine and only one patient has been treated. This patient had his surgery in 2016. He had a Gleason 7 4+3 T3A focal. He later on went on to have, he had a decipher of 0.46. Later on, his PSA started going up. He didn't want to jump onto the radiation. So we sent his tissue for the genomic analysis. We found that there were 728 annotated genes. There were 12 which were good for making a vaccine. We got the vaccine. These were the different genes which were abnormal. And we got this patient vaccinated early this year. His PSA at that time was about 4-ish, and now he is hovering around this. He has not been treated by any hormones, not been treated by any radiation, and it's been very short for him. During this journey, I also became a site PI for a couple of KLK3 and some different kinds of CAR-T therapy trials also. So I got a little involved with the immunotherapies for prostate cancer. They are pretty intense modalities, meaning people stay in an ICU for some time, cytokine storm happens. Nothing of this kind happened in these two cohorts of patients. So I had a strategy that I wanted to make prostate cancer a little bit more immunogenic with the least amount of any side effect to the patient. It seems like we are on the right trajectory. This Neo-Adjuvant trial, which we did using poly-ICLC, now is about so close from an FDA to get an approval that we will be using it for what we call an active surveillance. Now we will use it for those patients who are keeping on an active surveillance and they seem to have a little bulky tumor. We can inject that every year and see what happens. And BGB trial is going on anyway. So that's been my journey from a surgeon to looking at other options. Of course, I can give hormones. Of course, all other new kind of treatments are there. But this is a journey, and I'll be naive to think that this in isolation will take care of the problem. So we have a couple of trials in the cooking in which we are combining other modalities, other less painful modalities with this modality, because in order for immune cells to get something, they need to see the antigen. And if some other modality is killing the cells, then the antigens are getting exposed. They call it antigenic spread. And then this modality can bring in the good guys, and then that process can start. So I'm looking at androgen deprivation combined with this. I'm looking at HIFU combined with this. So you do the focal therapy and simultaneously inject this, see what happens. These are the clinical trial discussions. They are not standard of care. But I will take a moment to thank Dr. Isaac Kim and all of you for inviting me. And really having a journey, it forced me to think about things, and I really learned a lot from you and everyone else. Thank you.
Fantastic talk. That was really exciting. You know, your initial video shows this kind of evolution of a cancer from grade 3 getting more aggressive to 4 and 5. But when you look at prostate cancer, you don't see like 3 adjacent to 4, adjacent to 5. They're like multifocal. It doesn't really show that evolution that you describe. The reason I say that, it kind of is, I'm presuming 5 is a different beast, and you're not killing all of your cells with your immunotherapy. You're downgrading it. You're killing the higher grade cells.
That's right. The bad guys having more antigens, more mutations, and they are getting selectively killed. But what I just heard was, it looked like a continuum, one cell becoming 2 to a million, and that same clone. Now, prostate cancer is a multifocal. So bad guys may be in a small cluster somewhere else. And that is the picture from Hopkins shown in every anti-focal therapy trial, that the bad cells can come from any part of it. Index lesion usually is the one. But more mutagenic the cancer is, more likely it will get picked up. And it is a continuum process. The heterogeneity happens in a spatial manner, and it also happens in a temporal manner. It also happens between the prostate and lymph node may have a different clones of cells, and within the prostate left side may have, like yesterday's cell, the Gleason 6 on the other side versus Gleason 7, 4 plus 3 on the other side. They're different clones. But till we can use imaging to identify the clone, we are a little bit at a handicap. So we are trying imaging and targeted biopsy to map it out better, but that's a very good point.
Thank you, Dr. Tewari. That was, inspiring and very thought-provoking. I've never heard, we've always accepted on face that prostate's a cold tumor, and I think that mechanistic explanation makes a lot of sense.
It's a hypothesis. You guys need to help me, and
but of course, intuitively makes a lot of sense. What is your thought about, what is continuing, so you can make a cold tumor hum, what is keeping it cold? I mean, is there some signal or some infrastructure that's inherently lacking in the prostate?
Either there is a suppressive supply coming ongoing, or it's being locally generated, or is it a physical barrier, or is it such an ignored organ that body doesn't care about it? I mean, we don't know. I mean, one of these explanations has to be there. So that is where our active surveillance sequential biopsies can be a good source for study for these things. And reason I chose this talk, first I was going to give a talk on the racial disparity. I changed this because I thought I'll get some feedback and maybe collaborations from you all in this thought, because I need help.
Yeah, I mean, exactly, because I think it raises the question of how frequently you would have to, what is the turnover, right? So you waited 6 weeks after the injection. I guess the question is, how long will the effect be?
So I think we have these patients, we can at least systematically look at their markers, and at least in an active surveillance, they're getting PSAs and blood draw every 3 months. So we will know about what's happening in this. I cannot poke into the prostate every 3 months, but I definitely can, blood is drawn. So if there's a urinary marker, we can look into urinary markers for hot and cold tumor also. We can look into something, post-prostatic massage, pre-prostatic massage, those kind of things. And I mean, we don't have the answer. I mean, but basically it looks like whatever it was cold, the same patients, it became hot. And I think we know about the boosters.
Yeah.
So we may think about the boosting And that's where the active surveillance cohort, we can give the booster. But in this cohort, we have not given beyond how many weeks the intramuscular? So we haven't given anything since that point. They are 5 years, 40 months from the first injection. So if we give a 6-monthly booster, I don't know.
And sorry, if I may have one more question. How important do you think intratumoral injection is versus intraprostatic?
Intraprostatic meaning intravascular use. I think so. Okay, I got the point. When I inject into the tumor, I think it diffuses. It's unless and until I tag it with some gel that it only stays there, and I don't want to stay there. But it's a simplistic way as a scientist, he thinks that I have injected into the tumor, the neighbors also will have the same kind of thing. But geographically farther you go, less impact. So right apex versus left base, I think we have some hope.
When you examine the prostate after you take it out, do you see the changes diffusely or mostly?
So one thing which I was very nervous about, that as a surgeon, am I going to complain during the surgery? So I'm not exactly. And in pathology, I think it is more, I don't think we did the analysis of this coldness and hotness across the different parts of the prostate. You are picking up the most important part. So I don't think we have that information. But those tissues are there.
I think just to the comment about that, again, that's my gut feeling when I say about cytotoxin. So one of the things we're trying to do is in our responder as well. So in earlier analysis, we're seeing some responders in this trial. So what are the potential explanations? And I do think the immunotherapy is probably, immune access impact is probably one of the, for me, that's the most compelling explanation as to why when you have a leukocyte reduction, that you're seeing a systemic response, right? So we're looking for funding agents first, because I think it's another striking or important correlate that we're planning on doing. Maybe you can even take a look at this in those cohort patients. I think what you're seeing in terms of those factors you're seeing. The second question that I have for you is the immunization. Does it have to be into the prostate in your mind?
So PGB is not in the prostate. Personalized genomic vaccine, which we are doing it, we are just doing it intramuscular. So that is now in the rest of the body because there is no prostate there anyway. But in the Neo-Adjuvant setting, I thought that if there is an access issue, there is an EME issue, there is an capsular blockage issue, there are hypoxic zone issue, I can bypass many of them in one way, which is by getting into the tumor. So that was my theme on that, because why it is cool, because the cells may not reach there. There may be a hypoxic zone, there may be a chemically not friendly zone. So in order for it to come from, instead of driving from New York to here, I just airdropped it into that area where the problem is.
That's what I was wondering, borrowing from the testicle perspective, is you have a blood testis barrier, physical barrier preventing the immune cells from reaching the organ. And you're injecting the vaccine in there, but how is the immune system bypassing that physical barrier? So the signal is strong enough at that point.
So that testicular barrier, I'm glad it is there because I don't want this to reach the testes. But I don't think, at least, I don't know of a blood prostatic barrier. But it may be in chemical inhibition that, hey, it's like in President Barricade is coming, there are a lot of cops before that telling that, hey, don't touch this, this is important cargo. So in that process, it's just kind of getting suppressed.
The background for my question is that because there's a paucity of immune cells in the prostate, and because this neoadjuvant protocol you're running will give a relatively short time to see results, the question that I have, would you be enriching your results and have more proof of concept if you were doing something like this in Isaac's kind of patients, the ones that have measurable disease with locally advanced disease and nodes that have, faster growing, less time to have reaction, more immune cells present to have some sort of finding.
I agree. I mean, I think this ties to the Isaac's second question discussion, that when you're doing in an locally advanced cancer or in what we call in psychoreductive surgery, if someone can measure the circulating DNAs and circulating cancer cells at the time when you're taking it out, there may be a little boost happening at that time. So these are auto-vaccination happening by the process rather than by design. So you may be auto-vaccinating this thing just by, and then there may be a different way. Some people may be tapping the vein before, and that may have a different discussion. So you may already be auto-vaccinating that group. Only thing is that we haven't given a message to the lymphocytes before. So if you have this patient already injected something, so the body is immune mechanism expecting something, and at that time the surge happens, they identify the T cells identify the MHC class 1 and class 2 molecules, then it could be a different discussion. But most likely it will work in these settings, and that's the reason I got an idea, and I'm going to request that those two patients who had a persistent PSA, right? I didn't expect them to be cured by immunotherapy. They are your kind of case. Follow them up, see what happens. I don't think I have a follow up. I at least have not looked at it. What happened with those two patients who had a persistent PSA? Two patients out of these 10 to 12 had it. One was 7 and one was 9. So.
Do you know if anyone like in Isaac's patients that have advanced disease who've got the bulk of their prostate tissue removed but might have disease left over, if anyone's doing like a PSMA mRNA vaccine for those kinds of patients?
So we have got a couple of trials going on in which we are tagging the PSMA with these molecules. So this could be a good candidate for something like that. I must say, today you all must be very excited about immunotherapy, but the rest of the world, immunotherapy is not very high in the prostate cancer scene. So I'm just putting things in perspective. This is an exciting for me because that's what I deal with it. But there are a lot of unanswered questions. What I want to say is don't give up on trying something new. So that's the theme. As a resident, I don't want you to walk around behind me. So
That was a good close, Dr. Tewari. But that said, I also echo what he's saying. Actually, I think we're kind of on the same page here. I do think that for prostate cancer immunotherapy, there's something missing there, I think, in terms of preventing it getting it's for us to figure it out. But I think once we figure this, I think it's going to be another, I think, paradigm changing. I do believe what you're pursuing, Dr. Tewari. Okay, again, thank you so much and for coming and you just talks the last 2 days and just inspiring.